Hello, and welcome to the NRMN Health Research Talk. I'm Ann Smith. Today I'm talking with Dr. Ken Saag. Dr. Saag is Lowe Professor of Medicine with the UAB Division of Clinical Immunology and Rheumatology, and Director of the UAB Center of Education and Research on Therapeutics, or CERTs, and Director of the Center of Outcomes Effectiveness Research and Education, or COERE. Welcome,
Thanks,
Dr.
Ann.
Saag.
Good to be here.
Good. We're so glad that you're here. What will we learn today about comparative effectiveness research and patient-centered outcomes research?
Yeah, a hot topic, one that's really been changing rapidly. I'm going to talk a little bit about patient-centered outcomes research, which is the new buzzword. Comparative effectiveness research has been what we've talked about historically, and I'll kind of make some distinctions there. And then I'm a rheumatologist, so I'm going to give some examples from arthritis and osteoporosis, focusing on the use of large databases, talking a little bit about large simple trials, and also talking a little bit about healthcare measurement and implementation science.
Very good. It sounds very interesting.
Great. Well, I think it's good. You know, when we think about translational research, we often think about the early phase of translational research, this idea from bench to bedside. And outcomes and effectiveness research really moves us into the later phase of translation, where we're thinking about epidemiology, health services research. How do we go not just from the bench to the bedside, but as we say it, from the bedside into the backyard? How do we get the word out into the community? How do we implement evidence, translate research into practice?
Very important question.
There's kind of a series of overlapping Venn diagrams that I like to use that kind of speak to the similarities between terminologies, but also highlight that some of these things are indeed a bit different. So we can think about the new patient-centered outcomes research. We have a new institute now that is supporting a lot of this. Comparative effectiveness research, in fact, is one of their main focus areas. The oldest term is health services research, and that was what the Agency for Healthcare Research and Quality, and in its older iteration, AHCPR, used to support and still does support. And then another area that we've been very interested in here at UAB, and that has really been one of the tenets of this, is pharmacoepidemiology.
Yes.
So PCORE is the new institute, and this is a group that actually spins off of the Affordable Health Care Act. It provides a trust fund where each time somebody purchases either public or private insurance, $1 goes into the trust fund. Mm-hmm. And ultimately, they've got about $500 million to support research. You can see some of the different areas that they've been supporting, from assessment of prevention, improving healthcare systems, communicating and disseminating research, addressing disparities, and methodological research. Now, they've moved into some new areas. They're actually focusing now heavily on pragmatic trials. That's been a big focus area. And while a lot of their work initially was investigator-initiated, many of their new requests for applications are actually very targeted. So they're responding to what they, through discussions with patients and other key stakeholders, what they believe some of the most important topics are. One of the other great things about the PCORE activities is that they've actually spun off PCORE-Net. PCORE-Net is a group of clinical data research networks, CDRNs, and also patient-powered research networks, or PPRNs.
Yes.
And there's a whole series of these now across the country that are figuring out ways to exchange data, to use common data models, to collect data directly from patients in the community, and to integrate all this into research. So it's a very powerful engine to do research that nicely complements the clinical trial network, the CTSAs, the clinical NCATS-funded activity, as well as the NIH Research Collaboratory. So let me get into one of the areas, and
yes.
I put up here a few of the different domains of health services and comparative effectiveness research. Time doesn't permit me to cover them all, but I want to focus on at least 3 of the key ones. I'd like to start off talking a little bit about longitudinal cohort studies of effectiveness of therapeutics and other interventions. And this is a figure that I've found very helpful over the years, that one of my colleagues up in Canada developed, that reminds us that there's both evidence generation and evidence implementation. And these are sort of separate spectrums of the research specter. So we have to start off by generating the evidence, and that's an area.
number one.
That's the first circle, and so that can be an observational study and an interventional study. And then we often, if the studies are underpowered or we don't have enough evidence just from a single study, we might start to move those together and do meta-analyses, systematic reviews. Ultimately, that may result in guidelines. It may need economic analyses to understand the cost implications. And from those, we can then develop measures of quality. What's the least we should do in a given circumstance? A performance measure, a quality indicator. And the standard baseline of health services and outcomes research has been measuring variation. And normally, not always, but normally a significant variation in care across geography, across race ethnicity may suggest that this really constitutes an area where quality improvement is really needed. And that's where the final area, translating of research into practice, ultimately trying to impact healthcare policy is very important.
So it sounds like an iterative process of going through all
Indeed
of that.
It is. That's right. And then information from that should feed back and telling us where we need to generate more evidence. So let me give an example. A great study, one of the most famous cohort studies, is the Women's Health Initiative. This was a large NIH-funded study, $100+ million study that is still going on in its later iterations, that looked at the safety of estrogen either alone or in combination with progestin in cancer and in heart disease and in other outcomes among postmenopausal women. And so we can see that while there was some unexpected findings at the time of an increased risk of heart disease and breast cancer, we see relative risks that show a 25 to 30% increased risk. The confidence intervals shown next to the relative risk in most cases don't include 1, so these are significant confidence bands. And that gives us the relative risk, but we're also interested in a population estimate of the absolute risk. What is the risk difference? And you can see for these same outcomes, what was the excess or reduced risk per 10,000 women that were treated in the same set of outcomes.
So what do the numbers mean in that column of the excess or reduced risk?
So in terms of hip fractures, for example, this was the first large study to show that we could actually reduce the risk of hip fractures. There were 5 fewer hip fractures among 10,000 women who were exposed to the estrogen in this study. And in contrast, 7 more cases of heart disease, 8 more incidence cases of breast cancer occurring. So really some balancing of risks and benefits, as is often the case. Now, one of the things when we see data like this, we should always ask, and these are associations, statistical associations. Is it a true association? Could it be due to chance? And that's where the statistical p-value is very helpful in assessing the possibility of a type 1 statistical error. Or could it be due to confounding or bias? And I want to say just a word more about those two things. Bias represents a systematic error in the study design, and that's something that really has to be addressed at the start and in the design of the study. It's very difficult to handle analytically. Confounding is this false positive association between an exposure, in this case estrogen, and the outcome, something like heart disease or breast cancer, occurring. A classic example of confounding is what appears to be an association between alcohol consumption and developing lung cancer. Well, probably not a direct association, but we know that people historically that have been higher imbibers of alcohol have also been more likely to smoke. So alcohol is indeed confounding the association between smoking and developing lung cancer. Most of the time when we're doing observational studies, we're talking about risk factors. And we want to be careful not to just look for the light under the lamppost. Risk factors are very important, but they often just give us a clue, and they may be hypothesis generating.
They're not the cause.
They're not necessarily the cause, but thank you for mentioning that, because it really brings us to what is a cause and effect.
Yes.
And from observational studies, it's very hard to assess cause and effect. But we do have some principles put forward by Bradford Hill many years ago that are still very relevant. The strength of the association. Is there a dose response? Is the finding consistent with prior observations? Was there temporality? Did the exposure occur before the outcome developed? Is it biologically plausible? Does it make sense? And is it reversible? Sometimes that's not something you can actually look at. But these are all of the criteria that we use in trying to judge the likelihood of something potentially being causal. We want to be very careful, though, about saying something is causally related, particularly from an observational study.
Yes.
Well, here's another example from some work we did now over 20 years ago, where we were interested in the association of glucocorticoid medicine, steroids, if you will, and developing problems in the bones and in other bad outcomes. And this was a group of patients with rheumatoid arthritis, half of whom were on steroids, the other half of whom were matched by age, sex, and duration of their disease to non-steroid users. And you can see some of the very serious things that can occur: fractures, cataracts, infections. So it really creates kind of a concerning picture. And here we can see it in a Kaplan-Meier curve, where you're looking now in the very bottom curve of the people who were on the highest dose, and in the very top curve in green, those that weren't taking prednisone, the control group.
And what does it show?
Well, what it shows is a dose response, and that is, as you have more exposure to prednisone, you have a higher likelihood of experiencing an adverse event, which we just saw the listing of in the last slide. So the y-axis is the probability of remaining free of an adverse event, the survival, if you will. And if you were not taking prednisone, just based on having bad rheumatoid arthritis, at 5 years you had about a 20% likelihood of getting one of these bad outcomes, compared with about an 80% risk for those who were taking between 10 and 15 milligrams. So again, a pretty concerning finding, and we can look at it further in a multivariable way using logistic regression, where now we're analytically accounting for the presence of rheumatoid nodules and the changes in the bone of rheumatoid arthritis, two things that we know indicate more severe rheumatoid arthritis. Both of those were significantly associated with a bad outcome. But even after we analytically adjust for those, we still see this dose response. We still see the increased risk of developing a bad outcome in those who were receiving glucocorticoids. Now, one of the things that you should be worried about in such a study is this possibility of a selection bias. This is the biggest threat to the validity in therapeutic epidemiology. Sicker patients get treated more aggressively. The doctors and patients don't decide by chance to take prednisone, but they realize the disease is worse, and as a result, they suggest a more aggressive course. The other concern is that if you follow people in a differential way, you may be more likely to detect an event, so-called detection bias. So these are two of the risks to validity of these types of studies. Well, can we use clinical trials to fix these issues? That's one of the questions that always comes up. And we know from the evidence medicine people, the folks up at McMaster's, Gordon Guyot and Haynes and others who have really led the field in defining what is the top levels of evidence, that clinical trials are towards the top, whereas our observational studies are further down. But unfortunately, just looking at the steroid example, even for things that are relatively common, like a 10% rate of a bad outcome in patients overall, and a 50% increased risk of developing, say, a broken bone, so an odds ratio of 1.5, you need very big numbers. And many of our clinical trials in this particular area just are not going to have over 1,300 people in them. So we've got to see a twofold increased risk with fairly high rates at baseline to be able to have a study that is going to have the power to pick up such findings. So trials often have some practical limitations. Are there other things we could do? Are there other data sources we can use? And the FDA has been criticized for not moving fast enough. Some of our lay publications tell us that why don't we just use these large databases that exist for the purposes of billing patients and billing the payers of healthcare. But we have some strengths and limitations here that I want to review with you.
Okay, thank you.
So observational studies based on claims data have a lot of power, but they also have some limitations. And we think about all the health care that's delivered by the government, by private payers. It generates lots and lots of information. Each time you come in to see the doctor or get a procedure or a test, there's a code. There's an administrative data code that is generated. And all of this can then be concatenated and kept in large databases. So for example, Medicare data, Medicaid data is available nationally, and it can be purchased and used by academic sites such as ours. And with that, we can also include sometimes prescription drug data using the Part D benefit now of Medicare, or if you work with a group like Kaiser, say, where there is a pharmacy benefit as part of the health care that's delivered.
So here's a listing of some of the database resources.
Yeah.
And with
yeah.
the peer
so I
group.
mentioned Medicare, I mentioned Medicaid, Aetna, another large insurer. Another great source is the VA. Really terrific in that they, for many, many years now, have had one of the real gold standard electronic healthcare records. So not only do we have the administrative data, the ICD codes, but we also have actual electronic data available. Mm-hmm. Not always easy to get to in a standardized way. Sometimes it requires things like natural language processing to abstract information from that in a systematic way, but very helpful. Let me give an example from arthritis by one of my colleagues who has been interested in working with large databases to show how these can work. And there's a group of medicines out there now called the anti-TNF drugs. You hear about these on TV. These are drugs that are very potent and very efficacious in improving disease activity in conditions like rheumatoid arthritis and psoriasis, and even for kids that have juvenile arthritis.
So they help with those conditions, but they also have some side effects.
That's exactly right. You never get something for nothing with any drug. And the challenge is that we believe these drugs, like many drugs that suppress the immune system, could lead to some problems, particularly infections. So it was starting in the early 2000s that we began to recognize that there may be some possible adverse effects. And I use the word possible because it's back to the same issue of this confounding by indication. Is it really the drug, or is it that more severe patients are actually receiving these therapies? Mm-hmm. So here's an example of one of the warnings that was listed for the development of a particular kind of cancer, lymphoma, with one of these drugs. And so my colleague Tim Buchelman here at UAB looked at this within national Medicaid administrative data and determined the rates of malignancy among children with juvenile inflammatory arthritis, the most common form of inflammatory arthritis among children. And what Tim found is that yes, kids that had juvenile arthritis regrettably did have an increased risk of developing malignancy, but it didn't seem to be particularly associated with this class of drugs. So we used the power of this administrative data to help really understand that question. So what can this kind of data do well? Well, it can utilize large national data sets that have fewer selection biases. It can provide generalizable studies of effectiveness and safety. And importantly, it can complement other approaches to adverse detection at a relatively low cost. So if you can link a registry or you can link a cohort to administrative data, that can be a very useful resource. There are some challenges, though, with using administrative data.
Yes.
There's problems around accurate classification. There can be difficulties defining disease activity and severity. It can be difficult to figure out whether it's a new case or an old case. And we often don't have detailed information on comorbidity, so that can be a real challenge for administrative data. Not everybody's a big fan of doing observational studies. Here's some of our colleagues in Canada again suggesting that if you find a study that was not randomized, we suggest you stop reading it and go on to the next one.
Yes.
Others have been a little bit more sanguine, saying that we need both observational studies and randomized control trials, that they answer different questions. John Ioannidis has been one of the biggest heretics of observational data and provides some information that looks very discouraging, that even well-done studies may miss the truth in many cases. But I think in support of observational studies, when we go back and reanalyze some of the original observational studies that discounted what the Women's Health Initiative showed, and we do that using newer methods of epidemiology, we actually get very similar results to the randomized controlled trial. So well-designed observational studies have not been shown consistently to systematically overestimate the magnitude of effects. There's little evidence that the effects of observational studies in later time were either consistently larger or qualitatively different. And overall, I would argue that it's not fair to compare good randomized studies with bad observational studies.
A good point.
We just have to do a better job with the observational studies.
Yes, so there's a place for observational studies.
There has to be, because we can't randomize people to behavior or to other things where we just, and where we don't have the numbers in the population base. So let me move on to another area that I think is really important in the realm of comparative effectiveness research, and that's this idea of doing real-world or pragmatic clinical trials. And I want to emphasize what we mean here. And there's really been a lot of questions about how do we do clinical trials better? What are the problems with clinical trials? I've highlighted a few already, but they've been difficult to do. They often don't answer the right question. They suffer from poor generalizability. The people in the studies aren't really representative adequately, and they're often just not big enough and representative of people that we care about. So the movement that has been underway for many years but has really gained some traction under PCORE is this idea of doing pragmatic clinical trials that measure real-world effectiveness. They are larger, they have more generalizability, they often have minimal eligibility criteria, simple treatment approaches, and fairly simple objective outcome measures that should be patient-centered. They tend to be more generalizable, but they suffer a little bit in having less internal validity, in contrast to traditional randomized controlled trials that have poorer generalizability but better internal validity. So it's really a question of efficacy, which is what a traditional registration RCT shows you, randomized controlled trial, and effectiveness, which is what a pragmatic trial shows you. So traditional clinical trials suffer from the healthy person effect. They have very tightly controlled circumstances, very strict protocols, often very good adherence, or maybe a placebo run-in period that avoids having challenges with adherence. Pragmatic trials may take all of those things away and try to make it much simpler. Let me change gears and say that the explanatory clinical trial ascertains whether the new treatment actually possesses the favorable activity in man which laboratory studies have led us to suspect. Can it work under ideal circumstances? This is an efficacy trial.
Yes.
A pragmatic trial assesses the practical value of a new treatment in relationship to other existing treatments. Does it work under usual circumstances? And the synonyms include effectiveness trials, management trials, and often we use the term large simple trial, although not all large simple trials are truly pragmatic. So the two are just a little bit different.
And then the difference is looking at does it work under usual circumstances compared to does it work under ideal circumstances.
Perfect. Exactly. Yes. And it's a continuum. It's not one or the other, but we can think about the example of patient compliance. We can look at a continuum between explanatory and pragmatic. We can exclude people who are non-compliant before the study starts, such as with the run-in period. That would be very explanatory, or we might apply a compliance improving strategy to all the patients, or maybe just monitor compliance and intervene if it's low, or maybe we just monitor only, or perhaps we just ignore it entirely, and that would be the most pragmatic of all study designs. So we've put together groups of stakeholders and researchers and trying to understand how do we do a better job and a cheaper job of doing pragmatic trials. These can be very, very expensive studies to do. So we think that by using new practice networks, by figuring out new ways to do the informed consent more efficiently, and by linking people to their data, the data that's collected for billing purposes, we might be able to more effectively and more efficiently do pragmatic clinical trials.
So this chart then is describing how that can happen with all the
Yeah.
detailed pieces
Yeah,
of
some
it.
of the different groups that are involved, where in the process we could possibly innovate in improving things, and just giving some ideas about what ways we could do these better and cheaper.
Very good. And you're finding out some ways that work.
Well, we're trying. We've designed a study with support from the NIH, which we call the EDGE study. You know, coming up with the acronym is half the battle.
Yes.
We thought this one was kind of cute.
It is. It's
But
great.
so far, they're still struggling to find the money to do this big study. This is a very expensive study, answering a question about how long should you take your osteoporosis medicine, a very important question, since half the people now that were using these drugs 10 years ago are taking them currently. This has been a major change in our quality in osteoporosis, and we're very worried that we may see some of the reversals and some of the benefits that have been achieved at a societal level.
Because of those side effects.
Well, based
that
on
are
rare side
dose
effects
response.
predominantly, and that's, well, yes, and I didn't talk too much about that today, but I'd be delighted if you invite me back to talk more about some of the work we've done looking at some of the rare side effects of some of the bone medicines. But that's exactly it, and you get side effects that are 1 in 1,000 or 1 in 10,000, but they're very poignant, and that heuristic tends to affect the way people think and talk and the way doctors behave in using such drugs. So we're trying to understand exactly how long people should be on these drugs. And one of the strategies is to partner with groups like the HMO Research Network to try to find a lot of people. In this case, we need about 10,000, so looking across networks for this, and coming up with websites and other resources that we believe would be very helpful in designing such a large pragmatic study. So let me move into our final area and talk a bit about evidence implementation and dissemination. This is another theoretical model developed by some of our colleagues here at UAB, now at some other great institutions, including Vanderbilt and University of Massachusetts, that reminds us about how these translational blocks align, and that in implementation science research, we're in this later stage, we're in this final translational block of really trying to translate research into practice.
And that includes the policy and the overall healthcare systems.
Ultimately it does, and that's policy, in my mind, sort of equates with politics, and then it gets kind of out of the hands of academicians. But ultimately, to really impact true change, we need to affect healthcare policies. You've got to generate the evidence, you've got to show that it works in the real world, and then you've got to convince the payers and the policymakers that this is a healthcare intervention that's worth it and that we want to implement more widely. So the classic framework of health services research is to try to transition people from state 1 to state 2, state 2 being a better health state. And we can do this by focusing on the process of healthcare, by the structure where we deliver healthcare, and that ultimately has an impact on the outcome. So when we do outcomes research, we're often measuring process. What is it that we should be doing? And then we may translate back to a clinical trial and say that, well, we know if we get more people using this medicine, that they ought to have a better outcome, that the evidence is there from a really well done phase 3 randomized controlled trial. So I call that sort of the transitive property of outcomes research, where if you can improve process and you can show that by improving process that should have an impact on outcomes, you really ought to be able to impact an outcome even if your study is not designed to look specifically at an outcome. So what are the tenets of this area of translating research into practice outcomes research? That it's not geography or ethnicity that should determine which treatment a patients receive. Variations are often associated with differences in outcomes, and that values and preferences need to be incorporated into clinical decision making. This was a landmark paper by Elizabeth McGlynn looking at the quality of healthcare, and the results were a little bit astoundingly depressing. That just slightly over 50%, but really only 55% of adults were getting the recommended care according to various process of care measures. So lots of room for improvement then, and still lots of room for improvement now 13 years later. Here's just an example. This is the underuse care gap, and this is an example of beta blockers, one of the very standard of therapy approaches to managing hypertension and heart disease. And you can see that it took many, many years from the time that we showed in the laboratory that these drugs were efficacious to we started testing them in humans and showing that there was definitive evidence that after a heart attack it was a good idea to take one of these, that it reduced mortality. But it took really just a remarkable amount of time before this got translated into practice, before there was a quality indicator. Now the good news here is that the quality measure developed by the National Committee on Quality Assurance, suggesting that if you've had a myocardial infarction, a heart attack, you ought to take a beta blocker, people are doing such a good job that we stopped measuring it. Now 90% of people after a heart attack get a beta blocker, so there's no reason to measure it anymore. So this is a success story. Other examples are not so good. So after fractures, after you break a bone, only 25% of people get treated or tested. So we've got a lot of upward room for improvement there.
Yes, and part of that is education to the physicians and healthcare staff too.
I think so. I think it's both about education, but education alone is probably not enough, and I want to give some examples of that and talk about some other strategies. Now, if we think about healthcare overall and problems with healthcare, underuse has been the traditional domain of quality improvement. Where are we not doing what we ought to be doing? There's been a greater movement, though, towards this worry about overuse. And many groups now, for example, have developed what are called top 5 lists. What are the 5 things in your area that you're doing that really have low value? So that's been a way for specialists to police themselves a little bit. And then another classic example of medical errors is misuse, where drugs are used inappropriately or unsafely. And that often occurs, unfortunately, in the hospital a lot. And we know that medical errors cause many preventable deaths. So there's been a lot of focus on that area, too. Here's an example of one of the top 5 lists in the series of papers led by Howard Brody in the New England Journal back a few years ago, speaking to the need for defining what is good value in healthcare.
And they're finding that there are some that are overused that aren't providing the value.
Very much. There, in our area, in rheumatology, we came up with a list that included things like getting MRIs for routine low back pain or doing using biologic drugs prior to trying other therapies that were more effective in people that had never tried a simple, less expensive drug.
And is some of that difficult when the patients want the MRI or want the other options and the physicians?
Well, trying to include patient preference is huge, and that's really what evidence-based medicine includes. We have to value in judgment and patient preference into decision making. The new wild card in all this, not so new, but the increasing challenge is that we have the payer telling us what we can and can't do. So it's often not up to the physician or the patient, but whether they're going to get strapped with a $1,000 copay if they want to take a particular therapy, unless they've tried something else first, for example. Now, one of the things that we're seeing a lot of these days is doctor report cards and hospital report cards. And I show an example of hospitals being compared, just here picking on our own University of Alabama hospital, which is a great institution, but we saw in one example where we weren't performing quite as well as we would like to be. So that's very motivating to the hospital administrators and to other people in trying to improve quality. Doctors now are getting star ratings to show how they're doing compared with their colleagues. We're all very competitive, you know, so this is quite motivating in many ways as a way to possibly improve quality.
Good.
How do we define it? Well, defining quality is never easy. There are definitions that the Institute of Medicine has put forward. Health services for individuals and populations that increase the likelihood of desired health outcomes are consistent with current professional knowledge, and that include efficacy, equity, efficiency, safety, timeliness, and patient-centeredness. Those are the dimensions of healthcare quality. So implementation research is the scientific study of methods to promote the rapid uptake of research findings and to reduce inappropriate care and improve the health of individuals and populations. It's at the intersection between research and quality improvement. using methods from health services research and qualitative methods, a type of translational science that goes beyond the bedside. What can we do? Well, we can give people printed materials. We can make them smarter. Doesn't work, unfortunately. Traditional continuing medical education. Physicians and other healthcare providers go hear a lecture, they get smarter, but seldom change their practice from that alone. Intensive conferencing, that may work around things like smoking cessation, but it's very resource intensive and costly. Computerized tools, reminders, all sorts of alerts now with our EHRs, these pop up and doctors figure out how to extinguish them and don't pay attention to them, so we have to make those more effective, but they have some promise. Outreach visits and a specialized type of outreach visits called academic detailing, pioneered by Steve Sumarai. We're getting out into the practice and having an expert come out and talk about what they're doing. That may have some merit as well. And then audit and feedback. We've had a big interest here in UAB in audit feedback. I've shown the report cards already. Does that work?
Yes.
And then what about a multifaceted, multimodal approach? That's another strategy that might help implement research into practice. So we've been interested in all these approaches and really testing to see what works and what doesn't work. Why don't they work? Well, there's lots of reasons why they don't work. And it's usually not about knowledge, but it's often about inertia and aligning incentives properly. Here's an example of audit feedback in diabetes. This was work by our colleagues here at UAB, where they used the local quality improvement organization, the Alabama Quality Assurance Foundation's resources to provide feedback to doctors in the community. They looked at different measures of diabetes quality. If you have diabetes, were you having your creatinine tested, your triglycerides, your cholesterol? Did you get vaccinated? Did you have your feet examined, your eyes? And were you having good long-term glucose control?
And what are the red and light blue and
red is
blue?
how you're doing, how your practice was doing. Blue was the statewide project average. And the darker blue, the lighter blue is the statewide project average. The darker blue is actually what we call the achievable benchmark of care. This is comparing your practice against the top 10% of your peers using a very specialized Bayesian adjusted quality metric that the folks here at UAB had created. And it actually, we found that this achievable benchmark of care performed considerably better than the traditional conventional feedback approach, and CMS actually adopted this as the standard metric for providing performance feedback. Well, we were interested in this in a different disease state. We wanted to look at this back in our arthritis patients, many of whom are on steroids, knowing that steroids, again, are bad for your bones, and we looked within a large healthcare population, within the Aetna healthcare population, to see how were people doing that were on steroids. Were they taking medicines to protect their bones? And we looked at 2 time points in the early 90s and then in the early 2000s, and we saw that, well, for women over 50, things got a little better. They still weren't great, but almost 2/3 of them were getting treated. But look at the younger women and the men. Very low proportions were being tested or treated, and that was very concerning to us. So we designed a clinical trial, a behavioral study, where we identified these high-risk steroid users. We figured out who their doctors were, and then we randomized the doctors on the internet to receive or not receive a multimodal intervention. So we had an intervention arm and we had a control arm.
And with the doctors?
With the doctors, direct to the doctors. And we looked at the rate of testing and treatment for bone health before the intervention and then again after the intervention. And the study was powered to show that with 75 doctors in each arm, we'd be adequate. It was using this achievable benchmark of care. We had tailor learning approaches here, interactive case-based approaches that adult learning theory suggested should work well. They could get a toolbox. They could have CME online. It was rolled out over a 6-month period to combat any decay that might occur.
What would be the decay?
Well, the decay is just that you lose the effectiveness over time. Even if it had worked, and here you can see the results at the very top in a traditional intent to treat analysis, which is the way we ought to analyze clinical trials, there was no significant benefit. No significant benefit. When we looked at the doctors who did just what we asked, those who went online and downloaded their material and where they read their feedback, we started to see some trends towards some benefit. So the per protocol analysis looked a little more promising. But it really suggested to us that in certain disease states, it may be different and that there may need to be a different teachable moment. And maybe it's not the physicians, but it ought to be the patients or the healthcare system that we ought to be targeting better in an area like osteoporosis. So one of our approaches is involved now in our evidence implementation science, the idea of narrative communication. Can we engage and activate the patient? Can we use things like homophily, where people can relate to people that tell stories that sound and relate to them? Yes. Can we use that as a way to motivate them to take action and interact effectively with their healthcare provider? It's been said that the power of narratives to change belief has never been doubted and has always been feared. And here's an example, again, in a different health area, but in hypertension, where you can see the benefits of, in this case, just showing a very grainy DVD developed in sort of a home movie style, sitting men, mostly African American men, down in the waiting room at the community hospital, at the county hospital, showing them this, stories about their peers who had experienced strokes and other bad outcomes from high blood pressure. And it resulted in dramatic improvement in blood pressure, a very significant reduction, more so than you would see in a typical clinical trial, and leading to a paper in the Annals of Internal Medicine. We've looked at other approaches. We've looked at a very low-tech system approaches where we just give women the ability to schedule their own bone density tests. Here they could go online, they could schedule a bone density test, and within 2 of the Kaiser health plans, Kaiser Northwest in Portland and Kaiser in Georgia, we were able to show a significant increase in the rate of osteoporosis testing that should be appropriate for women over a certain age.
By allowing them to self-refer.
By allowing them to self-refer, very low tech, similar to a mammogram or a vaccination, but just use a 1-800 number. And so simple things may work, but you've got to test them to find that out.
Yes.
So evidence implementation research, the first step is defining quality. We have increasing things we can use. It's a team sport. We have to have behavioral scientists, epidemiologists, clinicians, and it's not easy to do. Technology offers us promises. Theory-based creativity is key. As my colleague Jerome Allison often says, one size fits none, and the approaches really must be tested. I love this study by Saag, showing that in the traditional quality improvement arena where you do uncontrolled studies, they look great, 80% work. But when you actually use a control group, as we saw in our example with the doctors in the Aetna health plan, often you get a negative result. So you've got to test things to know whether they're really working. So I want to finish up by just mentioning that for people that are interested in outcomes and effectiveness research, there really are great resources out there, both at our institution, at many institutions throughout the country, and we really hope we can get more people interested in this very exciting area where there's now more federal investment, great opportunities with PCORE, with AHRQ, with the NIH, the CTSA network. All of these are tremendous places to get trained to do outcomes and effectiveness research.
Good, and definitely an area where researchers need to go into more and do more of the evidence-based
We can come up with the best therapies, but if we can't get them into practice, it doesn't do a bit of good. We need people to help us with that.
Yes, thank you so much, Dr. Saag. So, and if anyone has any questions or comments about this, feel free to email me at the email address on the screen, and I can forward them on to Dr. Saag. Thanks very much. Thank you for watching this health research talk. We encourage you to email us with any questions or comments. Also, please take a moment and complete the brief survey on the link on your screen. Let us know what you thought about it and how we can improve it for the future. Lastly, register on the NRMN website to sign up for the online mentoring and be a part of NRMN, the National Research Mentoring Network. Thank you.